We are live.
So you are
Good evening. Yeah, good evening, all. I welcome you on behalf of the Endocrine Society of India. This is the second module of gender-sensitive endocrinology, and today's topic is midlife crisis in men. Blame it on hormones. We have an international collaboration with a doctor from Turkey. We have an endocrinologist, Dr. Bülent Yildiz. I'll be introducing him. He is a professor of endocrinology at Hacettepe University of Medicine in Ankara, Turkey. His current research focuses on androgen excess disorders in women, especially polycystic ovarian syndrome. Also, he has a research expertise in obesity and neuroendocrine regulation of food intake and body weight. Currently, he is also the associate editor of Journal of Endocrine Society and a member of the nominating committee. He's also the founder and president of the Endo Bridge, which is an annual event in collaboration with the Endocrine Society, the European Endocrine Society, and the Endocrine Society of Turkey. Our other faculties include Dr. Zubin Jacob. He's the professor and the head of endocrinology at CMC Ludhiana. He has more than 100 publications with more than 561 citations. He will be actually speaking on the topic proper. And before that, we have Dr. Sudeep, who will be actually conducting the quiz. He is a professor of endocrinology at the Father Muller's Hospital in Mangalore. He has more than 30 publications to its credit. And we have Dr. Sheila Sheikh also, who is a consultant endocrinologist at the Saifi Hospital and OCAPS Hospital. Before we start, I would request our international faculty to speak a few words, and then we go over. Dr. Bülent Yildiz, please.
Thank you, Dr. Ganapati Bantwal. It's a pleasure to participate in this session, and I'm happy to be part of the collaboration between the Endocrine Society of India and European Society of Endocrinology. So I'm looking forward to the presentations of our faculty. Thank you very much.
Thank you. Now over to Dr. Sudeep for the quiz.
Sure.
You can, yeah.
Good afternoon and welcome everyone. We'll be having a small quiz on the topic today. Even though the topic is restricted to midlife crisis in men, I have included both men and women, and mainly I'm focusing on the theoretical part of the hormones, and I believe Jubin will be focusing more on the psychosocial aspects and more generalized this one, including hormones. So we'll take the questions. There are 10 questions. Each has 4 choices, and only one choice is correct. And you have to just write the question number and the correct choice, A, B, or C, or D for each question number. And at the end of the full session, then we'll be discussing about the correct answers and also about any clarifications. So we'll move on to the questions. This is a first question. Question number 1. According to Erikson's psychosocial crisis, midlife crisis involves which of the following aspects mainly? Only one of them is right. Generativity versus stagnation, intimacy versus isolation, ego integrity versus despair, identity versus role confusion. So Erikson's psychosocial crisis involves many aspects, and according to different ages, he has divided into different aspects involving different age groups. Only one of them is right. So I'll go on to the second question. Question number 2. According to STRAW, that is Staging of Reproductive Aging Workshop, which mainly classifies the perimenopausal period. In early menopause transition, which is true? A difference of more than 60 days in length of consecutive cycles, FSH more than 40 persistently, A consistent delay of more than a week in consecutive cycle, or all are wrong. So which is a correct statement? So this is a stage of reproductive aging workshop, which has classified the perimenopausal transition into different periods, and the features seen in early transition, mid transition, late transition is specified, and according to that, this question has been framed. We'll go on to the third question. Beneficial effect of androgen replacement in aging males is seen mainly in which aspect of a sexual dysfunction? Is it erectile dysfunction, ejaculatory disorders, libido, or all the above? So I repeat the question again. The beneficial effect of androgen replacement in aging males is seen mainly in which of the following aspects? Fine, it's a short question only. We'll go for the fourth one. So menopause rating scales include the following domains except, because the perimenopausal period and the transition basically has many non-specific symptoms. So when we are rating them, it becomes much defined to rule out other coexisting diseases, and also to try to specify some of the symptoms to the menopause. So there are various domains under which the rating scales have been done. There are many types of rating scales, and the most common ones use which of the following domains except, which aspects are taken, and among the four, which three are there and which is not there. Fine, we'll go to question number 5. In andropause, true about the pathogenic mechanism is declining Leydig cell and HPG axis, that is hypothalamo-pituitary gonadal axis, decreasing sex hormone binding levels and consequently altered free T levels, that is free testosterone levels, reduced aromatase activity, and declining testosterone receptor resistance. So which is true among the 4 mentioned pathogenic mechanisms in andropause? You all know andropause is similar to what we mentioned in females as menopause. So which will be the best pathogenic mechanism to mention the changes which we see in andropause? Is it declining Leydig cell and HPG axis, decreasing SHBG levels and consequently altered free testosterone levels, reduced aromatase activity, or declining testosterone receptor resistance? Which of them are true? Moving to the next question. In premature ovarian failure, true is menopausal symptoms and psychological symptoms are less severe than in natural age menopause. While replacing estrogen, the target serum estradiol level is around 30 picogram per ml. That is what we target. Ovulation is possible if serum FSH is suppressed to less than 15. And combined pill is more effective than hormone replacement therapy. So there are 2 types of replacements. One is sequential, and there is simultaneous. And then there is a combined pill. So which of them is more useful and most recommended in premature ovarian failure? So in premature ovarian failure, you have to tell which is true. We'll go on to the next question. The most correct statement regarding vasomotor symptoms is the altered estrogen is to testosterone ratio is responsible for VMS. Estrogen withdrawal reduces the threshold for sweating response to the core temperature change. Norepinephrine increase in brain also contributes to the exaggerated sweating response. Both B and C are correct. So which will be the most correct statement regarding vasomotor symptoms which occurs in perimenopausal period? Is it the estrogen testosterone ratio, or the estrogen withdrawal producing the effect, or increase in norepinephrine in the brain producing the effect and contributing to it? But both B and C are correct. We'll move to the next question. Sorry, this should be question number 8. All are true about androgen levels in men. This should be question number 8. All are true about androgen levels in men, except bioavailable and free testosterone correlate better than total testosterone levels with clinical sequelae of androgenization. B. Total serum testosterone consists of free testosterone of 5%, SHBG bound testosterone of 85%, and albumin bound testosterone of 10%. Sample collection for androgen levels should be taken in the morning, better before 11 a.m. And by aging, total testosterone levels fall at an average of 1.5% per year, while free and bioavailable testosterone falls by 2 to 3% per year as aging proceeds. So again, I remind you, this is question number 8 regarding androgen levels, not question number 9. So bioavailable testosterone and free testosterone correlate better than total testosterone when we are assessing androgenization. Total serum testosterone is equal to free testosterone 5%, SHBG bound testosterone 85%, and albumin bound testosterone 10%. Sample should be always taken in the morning before 11 a.m. and the TT falls by 1.5% per year, while bioavailable and free testosterone fall by 2 to 3% per year by aging. So now we are moving on to question number 9. This is not question number 10. Pick up the false statement. This is regarding hypoactive sexual disorder. This is question number 9. Bremelanotide was approved by FDA to treat acquired hypoactive sexual desire disorder in premenopausal women. Flibanserin, which is called the female Viagra, is used in postmenopausal women and for sexual enhancement. Randomized controlled trials have shown benefit of continuous testosterone therapy in HSDD, that is hypoactive sexual disorder. Ospemifene is a SERM useful for dyspareunia and vaginal dryness in menopausal women. So we have to pick up the false statement. This is again question number 9. So again, look carefully to the choices and pick up the false statement. Okay, we are going to the last question, question number 10. As per published data, which is true in Indian women, the average age of menopause is 46 to 47.5 years. It is called early menopause when it occurs before 38 years of age. And in Indian women, premature ovarian failures occurred at around 35 years on an average. All the above are true. So you have to pick up which is a true statement. It's some of the published data which are available, taking large population-based data, and they have published in one of the journals which is mainly dedicated for menopause. So I think this is clear. This is question number 10. So I think I'll hand over to the organizers.
Yeah, thank you, Dr. Sudhir. I think they were all very tough questions. We will be telling you the correct answers at the end of the session. I request Dr. Zubin to speak on the topic, midlife crisis in men, blame it on hormones. Over to Dr. Zubin.
Thank you. Thank you, Dr. Ganapathy, and thank you for asking me to talk on a slightly unusual topic. I do not have any research experience on this topic, and it's not something that is part of what we consider general endocrinology of aging. Midlife crisis is generally not part of it. And I think we've had a very excellent quiz. So almost all menopausal transition has been covered in the quiz. So that is why I'm limiting myself to midlife crisis in men and trying to see whether there is any contribution or anything that an endocrinologist can contribute when somebody or a man comes in what looks like a midlife crisis. So again, this is a very difficult topic because the definition of what exactly is midlife crisis is also not clear. Before I start, I just wanted to give you some case scenarios. Now remember, all these case scenarios are fictional people any resemblance to anybody alive or living is purely coincidental. So these are fictional characters I'm going to show you. This is the first person is a 47-year-old married endocrinologist. Now, what has happened is he thinks he's in love with his 25-year-old colleague at work. He also very seriously is thinking about buying a new Harley Davidson. He just saw a picture of the Supreme Court Chief Justice riding a Harley Davidson. He thought that if he can do it, why can't I do it? And he's also seriously, with all these webinars and the lockdown, he's seriously thinking of a career change. He's thinking that this giving this webinar, seeing patients, controlling their sugars, adding a little bit of thyroxine to patients with primary hypothyroidism may not be all that what he wants to do in life. So he wants to think about a career change. So this is one particular patient. So again, this is an audience question. If you want, you can answer this. Is he having a midlife crisis? Now let's come to a second person. The second person is actually similar. He's a 27-year-old married physician. He's in love with another 25-year-old colleague at work, exactly similar to what is happening to the 47-year-old. He's also seriously thinking about buying a Harley Davidson, but he's just a graduated physician. He probably cannot afford to buy a Harley Davidson. And he's also thinking of a career break. And in fact, he's now does not like the idea of treating all the encephalitis, dealing with COVID, and he's really thinking about specializing, maybe even becoming an endocrinologist. So he's thinking about a career change. So could he be having a crisis? Because everything that is going on in his head is very similar what is going on in the 47-year-old endocrinologist's head. Now, the last patient is, or the last character that I can think of is a 74-year-old. He's been married 3 times. I'm hoping it is November. He's an ex-president of the United States. And he's planning on his 4th wife, exactly the same. He's also in love with a 25-year-old colleague. He's also seriously thinking about buying a Harley Davidson. And he's obviously has to think about a career change because he's now the ex-president of the United States. So is he having a crisis? So these are 3 scenarios, very similar, but all of them, when we look at them, and I really want to ask the audience, how many of them actually think which of these 3 people are having a crisis? And though I'm not going to get any answers, but what I can see is all of them have one thing that happens to most of us in parts of our life, that is we have a fear of aging. So you can see all 3 of these individuals have this fear of aging, and they have this fear that they have not done what they should be doing in life. But then you can look at what really happens. What does the society think when they decide that they are going to change something? What is the social expectation? So you can see that the 27-year-old physician who now wants to pursue a career in endocrinology, it is in line with what society expects of him. Him being in love with a 25-year-old is exactly what the society expects from him. Or buying himself a Harley Davidson is exactly what somebody expects from him. While on the other hand, you can see the other 2 are non-conforming with what the society expects of them. So that is the reason why this, some of you might consider that the last 2 people are having a crisis, though all of them are going through the same thing, because it is not in line with what the society expects from a 47-year-old or a 74-year-old. It is considered to be not in keeping with what should be done, and it is considered to be a crisis. So I think with that little introduction, my outline of my talk is to define male midlife crisis, and this is going to be, I think, the most difficult task. At least I had a difficult time trying to figure out what exactly is male midlife crisis. Then we look at some of the components of male midlife crisis, look at what the hormonal component of male midlife crisis, and finally, whether manipulating the hormones. And primarily, when we are saying about manipulating the hormone, we are talking about testosterone replacement therapy. Is it going to make an impact on male midlife crisis? So this is the outline that I'm going to talk about. The most difficult job is to define what exactly is male midlife crisis. And this is where, if you go through literature, actually, if you go through PubMed for midlife crisis, there is no mesh term called midlife crisis in PubMed. So it is very difficult to get articles there. So you go to Google Scholar, you go to other places, and then you will get a whole sort of not just medical literature, but a lot of sociological literature, a lot of marketing literature, a lot of what we call organizational management literature. So depending on who is viewing it, I think the definitions are very different. I think the term midlife crisis was actually coined by what I would call a product manager who wanted to sell things. So a product manager looks at midlife crisis as a way to sell a certain aspirational items. A psychologist or a psychiatrist looks at a midlife crisis completely differently. A sociologist looks at it very differently. A clinician is going to look at it very differently. And by clinician, I think an endocrinologist is going to look at what midlife crisis is very differently. And then there are all these self-help authors. I mean, they need to provide a solution for what a crisis that is happening, and they need to provide some sort of biological explanation for why this crisis is happening. And they have a very different definition of what a midlife crisis is. So let's look at some of these definitions. And if you want to ask me who coined the term midlife crisis, it's a Canadian psychoanalyst. Now, this Canadian psychoanalyst was not really interested in helping individuals. He was actually employed by a very large company in the United Kingdom to look at how to get people working for the organization to contribute most productively. He was interested more in the organization than in the individuals who were part of the organization. So that, and some of the very common terms that we hear, like corporate culture, midlife crisis, these are all being coined by these Canadian psychoanalysts. His definition was primarily a definition made for an organization where the organization was made aware that there are these people who are going to fall into the 40s bracket, who are going to have slight dissatisfaction with their work. So you need to now put them in a different place, or utilize their whatever skill sets they have till that age and give them new challenges. And that was the real reason behind coining the term midlife crisis. And his definition was men and women around the age of 40 who are disillusioned with their current work, were disillusioned with their relationships, and were detached from family responsibility. So this is what he defined as a midlife crisis, and he's the person who termed this or who first used this term called midlife crisis. But again, this is an organizational psychologist, not really a psychologist who's interested in actual humans. Now, before we define what a midlife crisis is, we also need to define what midlife is. And midlife is not one point in life. It's actually what now psychologists believe is your middle adulthood. You have your young adulthood, you go into middle adulthood, and then you go into older adulthood or old age. So to define that, you could use what we call chronological definition, in the sense you look at what your average lifespan is. In India, it's about 70 years. So your midlife would be somewhere around 35 years. And if you want to call it mid-adulthood, it might, it might start from 35, extend up to 55, and that will be your mid-adulthood. In more better or in societies where the life expectancy is better, this might be between 40 and 60. So midlife actual point will be about the age of 40, and middle adulthood would be between 40 and 60. So that is one way to define midlife, that is chronologically. But there are some psychologists who believe that it should not be defined chronologically, because it might not give you the whole what we want from midlife. It may be a developmental stage in life. What exactly is this developmental stage? It is a stage where, in terms of financial dependence, it is, in midlife, this is a time when two sets of people are dependent on you. That means your children are dependent on you, and now for the first time, your parents are also dependent on you. So in developing countries, this is a stage of life where there are two people who are dependent on you. But at the same time, this also is a time where you probably are now earning much more than what you earned before. So you have a lot more financial freedom than what you had in your early adulthood. So that is one of the components of defining this developmental stage. The other component is what we call, or what psychologists call, a physiological decline in health. So this is the period of time where many chronic diseases start. You may develop diabetes, you may develop hypertension, you may develop many long-term chronic diseases, and there is a physiological decline in health in the middle adulthood. And this is something that is universal in sense it happens with everyone. For many people, this is a developmental stage where they have reached what they call a professional plateau. That means they have reached where they could in the sense, but at the same time, this could be also a time, middle adulthood, where people are experiencing a lot of professional success as well. Now, when we talk about emotional loss, I think the main emotional loss is middle adulthood is also the time when most of us or most humans will lose their parents. That means this is again a time where you have lost your parents, and also it may be a time where your children go away to colleges and they become independent. That is the emotional loss that this developmental stage has. And also it may lead to a lot of emotional maturity because you're now, for the first time, you don't have your parents and your children are away, and you start depending more on yourself and more on your spouse. So that's again another component that you may reach what they call the marital plateau. On the other hand, you may discover more intimacy, especially now that your children are away and now that you have more financial freedom. So this is what psychologists would call a developmental middle adulthood. So this is not chronological. When you reach this stage, you may reach the stage. I think in medical field, we may reach the stage much later. We may reach the stage only by 40, 45. For a politician, they might reach it only by 50, 60, while IT professional might reach the stage much earlier. So this is based on that. And finally, I think there is one group of psychologists who don't believe it to be middle adulthood to be either chronological or to be a developmental stage in life, but they feel that this is something to do intrinsically with what motivates us or what motivates us to be what we do. And this change in motivation is what signifies midlife or middle adulthood. So the primary change in motivation from early adulthood to middle adulthood is that in early adulthood, you have a goal and you are planning to achieve your goal. By the time the psychologists believe that the change in motivation in middle adulthood is that you believe that you have achieved those goals. More importantly, now you're worried whether you will lose those goals. That means what you have achieved, you might start losing it. So the primary change in your thinking about your motivation is maintaining what you have already achieved. And you can see that in many departments that some people, they're instead of looking forward, they start looking at maintaining what they have already achieved and trying to avoid losing what they have achieved. So this is a main change in motivation that some psychologists believe signifies middle adulthood. So these are the various definition of what midlife is and what middle adulthood is. Now we are coming to when do we call it a crisis? You have defined what midlife is, and when is that reaching the midlife, and when is it a crisis? I think, again, as we saw in that 6 blind men with the elephant, everyone has a different definition of what a midlife crisis is. If you, I think the best or the most robust definition or the most accepted definition is actually a psychological definition of a midlife crisis. That means at this point in time or midlife or middle adulthood, at one point in time, there is a rapid and substantial change in your personality. And this change in your personality, if it is for the better, it is not a crisis. But if it is going to dislocate your sense of identity and the way you identify with your spouse, the way you identify with your co-workers, the way you identify with your colleagues, the way you identify with your friends, if it gets completely dislocated, then you call it a crisis. There is a change of personality that happens in midlife, but it could be a good change in personality. It may be more adaptive. It may be more understanding, but the minute it starts dislocating one's sense of identity and you start having problems with relationships, it is considered psychologically, it is considered a midlife crisis. And I mean, that's also a time when this particular individual will start questioning the whole framework of his life, that how he, I mean, till the age of middle adulthood, the way he has framed his life, he starts questioning it. So this is what is a psychological definition of a midlife crisis, while a psychiatrist is probably not interested in all the change in framework of his life. He's more interested in how it manifests itself. So a psychiatrist needs more substantial things that he can work on, and when you change your whole framework of your life in question, you start maladjusting. You may present to a psychiatrist as depressive illness, as anxiety. You may present with substance abuse. Again, in midlife, it is very common to suddenly, substances that you used to take moderately, you start abusing these substances. You turn to alcohol, to other substances. And finally, there is something called a maniac flight, which a psychiatrist which in popular terms would call a complete breakdown. This is somebody who's not just had a minor crisis, he's actually had a breakdown. So this is how a psychiatrist would look at midlife crisis. So these are things that he can handle. Very difficult to handle the context behind this, but he's confident in handling some of the other expressions of this midlife crisis. While on the other hand, there are some sociologists who completely, now this is an interesting lecture I got online. This was I think, given in July 2019. And this is looking at the cultural roots of midlife crisis. That means we are programmed to have a midlife crisis, is what this particular author believes in. And the cultural roots basically comes in because there exists a socially prescribed timetable for ordering of major life events, which means that we are programmed in our childhood that there is a certain socially prescribed timetable for you. That means even when you are 10 years old, you know that you have to go to college at this age, you finish college at this age, you get married at this age, you have a child at this age, you buy your first home at this age. There is a whole socially prescribed timetable. The same with medical professionals as well. We have a timetable. You finish your undergraduation at this age, and when a 40-year-old applies for, let's say, an endocrine residency, everybody calls it as a person who has come for residency in a very late age. So there is a socially prescribed timetable. It's not written down, but I think it is there in all our minds and as we grow up. And that timetable was very different in different cultures previously. I think in the last 1 century, this has become a more homogeneous timetable. That means whether you are in a Western population, whether you're Chinese, whether you're Indian, the timetable, at least in the educated group of people, this timetable has become more homogeneous. You have a certain socially prescribed timetable for all these major life events. And there is also a consciousness of age. That means when you get married at 40, you are very much conscious that you are getting married at a late age. When you get married at 20, you are very much conscious that you are getting married at an early age. So that consciousness about each of these major life events is ingrained in us. And then there are also, because of longer lifespan, there's also what they call a competitive consumption. That means you see what your neighbors, you want to keep up with your neighbors, you want to keep up with your colleagues. And that is probably this cultural demographic homogeneity that has come in the last century. Is probably the reason why midlife crisis is recognized that is a socio-cultural or demographic viewpoint. Finally, we come to the self-help authors who want to put something that can be easily treated. So they want to define midlife crisis biologically. And this is not just self-help authors, even clinicians. As clinicians, when we see somebody in a crisis, it is difficult for us to imagine it in cultural sense, difficult for us to imagine it in psychological sense. We want to see what is really happening biologically. And I think various theories have been put forth. One of them is that in the middle adulthood, you have what is in men is called the middle age spread, or the adiposity that you see and the consequent metabolic abnormalities that you see. There is one school of thought, especially this is not a clinical school of thought, this is by self-help authors who believe that the origin of midlife crisis is in the metabolic alterations that accompany weight gain in midlife. Baldness, reduced vitality, and then finally some people believe that there is a whole set of hormonal turbulence that defines or that manifests itself as a crisis in middle adulthood. So because we are endocrinologists, I think I'll now limit myself to the hormonal components of midlife, male midlife crisis. And I think the first person to try and bring all these three things together was a general physician from New Zealand. I think these papers are, this is a paper in 2004, but I think he started writing about this in 2000, in the early 2000, 2002, 2003. So I think he's the first person who started looking at what was very obviously a clinical diagnosis, that is the aging male syndrome, or what we call ADAM, or the male climacteric or andropause. And he started associating whether this could be what is responsible or the biological basis for this midlife crisis. So that is Roger Carlton who first came about with this. But it is important to remember that this male climacteric is not something that is recent. This is a paper, I think, in 1940. Somebody has, one Dr. Werner has described almost 273 cases of what now we would think is andropause. So this is not something that is recognized recently, but I think putting the what was essentially a psychological diagnosis of midlife crisis and the male climacteric together, I think was only done in the last 10, 15 years. Just to highlight, I'm sure there is a next series of webinars includes a whole session on andropause. But I think just to remind us that there are various terms for it. People have called it male menopause, but again, male menopause is more of a term used by journalists and the lay public, not so much by doctors. We have called, many of us have called it andropause, but I think andropause is also not a true reflection of what really happens, because it is not a pause, it is more of a slow decline. So climacteric is probably a better term. Androclice is a slow decline in male hormones. But I think this is again a term which is used because of this number of terms which were confusing. I think the consensus was among the geriatric, the geriatric doctors, and the consensus was to replace all this with the term aging male syndrome. Or then we had what we call androgen deficiency in aging men and partial androgen deficiency in aging men. Now, these are all geriatric and sexual dysfunction societies that came up with these terms. And finally, I think as endocrinologists, we want to give it a much more clearer term. And the term that we use generally is late onset hypogonadism, which is a much more specific term. And now to try and bring, all of them signify the same thing. Now try and bring this and relate it to the male midlife crisis is something that I'll try and do in the next few slides. I think when we think about these various syndromes, we always think about patients in the late adulthood. That means over the age of 60, over the age. But we have to also remember that the decline happens much earlier. I'll show you those slides later. But I think the first papers that suggested that the decrease in testosterone was not just going to lead to physical and sexual problems, but also going to lead to a lot of psychological and psychiatric problems, where I think papers by psychiatrists which looked at the incidence of depressive illness in hypogonadal men. This was a paper in 2004. Subsequently, there have been a huge amounts of literature looking at depressive illnesses, looking at cognitive functions, looking at anxiety disorders, comparing hypogonadal older men with eugonadal men. And you can see from the Kaplan-Meier survival analysis that you have much higher chances or significantly shorter time to be diagnosed with a depressive illness if you are hypogonadal versus when you are eugonadal. And now this is not just a cutoff of in terms of hypogonadal. This also is dependent very much on what your testosterone levels is. Depending on whether you are sitting at 350 nanograms per DL, many endocrinologists will not call that hypogonadism, but I'll show you that there are some societies that believe anyone below 350 nanograms per DL is also somebody who has hypogonadism. So depending on where you are, whether you use as low as 150 nanograms per ml, you can see that the risk is now almost 30%. The 2-year depression incidence is almost 30% compared to when you were 350, when it's about 15%, and it's about 10% if you are eugonadal. So this is something that most societies, even endocrinologists, realize that there are a lot of psychological issues that accompany a decline in testosterone in men. Now, I think that is the reason why when we look at symptoms of possible aging men syndrome, now you have to remember there are 9 societies or 9 guidelines for what we call aging male syndrome or late onset hypogonadism or ADAM. Each of them have their little quirks and little differences, but I think what is now clear is almost all the societies include psychological symptoms as a possible relation with aging male syndrome. So that means even the Endocrine Society guidelines from 2018, they do not give it that amount of importance. They call it possible symptoms of late onset hypogonadism, but they have included psychological symptoms. And you can see these psychological symptoms include actual changes in mood, poor concentration, loss of motivation, reduced memory, anxiety, depression, irritability, general decrease in intellectual activity, and obviously sexual, endocrine, and physical symptoms accompany these symptoms. And if you look at the most commonly used questionnaire to actually decide whether you need to send a testosterone levels for someone who's older, I think the most well-validated questionnaire is the ADAM questionnaire. And if many of us have used it either as a clinical tool or as a research tool, and I'm sure if you've looked at it, there are 10 questions, and the answer is if you answer yes to question 1 and 7. Now, question 1 and 7, we can very clearly see are related to sexual activity or sexual direct sexual disorder. That means one is a decrease in libido, the other is erectile dysfunction. Question 1 and 7, the presence of any of these two. If you answer yes to either of these, you go on to, the ADAM questionnaire is considered to be positive and go on to hormonal assessments. But what is important is for other questions, there are 7 other questions in it. Some of them are very physical questions, like do you have a decrease in endurance or strength? Have you lost height? But also 3 of these questions are psychological questions. And if you look at those 3 questions, have you noticed a decreased enjoyment in life? Are you sad and grumpy? Has there been a worsening of your work performance? So these are 3 psychological questions. That means even if a patient who comes to you with what looks like a psychological issue, he may answer yes to 3 of these questions. And as per your ADAM questionnaire, he may not have any sexual symptoms at all. He may not have any physical symptoms at all, but because he has answered yes to these 3 psychological questions, you still need to evaluate him for testosterone deficiency or late onset hypogonadism if you use the ADAM questionnaire as a screening to decide whom to evaluate. So I think it is important to remember that pure psychological issues, if you can also manifest or can be a manifestation of late onset hypogonadism. Now, if we look at, the late onset hypogonadism, the societies that have guidelines on it, and male midlife crisis there is absolutely no guidelines on it. But if you consider these terms interchangeable, then this is a recent paper, I think, published months back, which looked at all the different available guidelines for late onset hypogonadism and looked at how they could be similar to each other and how they are different from each other. And if you look at, there are the 9 documents that are currently available. 2 of them are from endocrinologists. One is from the Endocrine Society, the 2018 guidelines, which was published in JCM. There is a much more what most of us would call more scientific or more endocrine basis from the Endocrine Society of Australia. But then there are also guidelines from the urological societies, from the American Urological Society, from the European Academy for Andrology, European Association for Urology. Then there are guidelines from the societies for sexual medicine. that is the British Society of Sexual Medicine, the International Society for Study of Aging Men, and then general guidelines from things like Canadian Medical Association. So there are fair large number of guidelines, and their guidelines are similar in many ways, but they're also different in many ways. So the first question is, if we believe in our mid-adulthood starts from the age of 40 to 60, is there a cutoff for the definition of late onset hypogonadism? In my mind, late onset hypogonadism happens to patients over the age of 50, over the age of 60. So is there an overlap between these two conditions? So I think looking at all these 9 guidelines, only 2 of these guidelines actually give you an age cutoff. And that is, I think, the Canadian Medical Association guideline and the British Society for Sexual Medicine, which actually tells you that the cutoff of age is 50 years to decide, call it late onset hypogonadism. For all the other guidelines, there is no age cutoff. That means patients who present to you in the 40s, in the mid 40s with what looks like a midlife crisis should also be evaluated for late onset hypogonadism, even if they only have psychological symptoms and they do not have the classical sexual symptoms. So I think it is important to remember that this is from a paper in 2008, that gonadal functions. I think we had a few questions in the quiz as well. Gonadal functions, especially the Leydig cell functions, that means spermatogenesis, the gamete, the gamete, the quality of the gametes are going to decline from the age of 35. So that means testosterone, the Sertoli cell function starts declining from the age of 35, but the Leydig cell functions also starts declining from the age of 40. So there is considerable overlap between the decrease in testosterone levels and the time period that you are likely to have the male midlife crisis. And this is, I think, I'm sure all of you know this, that the decline in free testosterone levels is much more dramatic, and it is associated along with an increase in sex hormone binding globulin. Now, if you're going to use the ADAM questionnaire and you find that a person coming with what looks like a midlife crisis has psychological issues, and you are going to use testosterone levels, and I think there was another question asked, if you're all these societies believe you have to check the testosterone before 11 a.m. In the morning, preferably between 7 and 11 a.m. in the morning. And if you're going to use that testosterone level to label them as late onset hypogonadism, or to try and bring that midlife crisis and late hypogonadism into a single unifying diagnosis, then these are the various cutoffs. You can see that the cutoffs are for total testosterone range from 350, which is the 2020 guidelines from the European Association of Urology, to the Endocrine Society, which 2018, which says that you lose a much stricter cutoff of 264. These are all nanograms per deciliter, and I think this is the values we are more familiar with. And you can see that there is no uniformity between these societies about what is the testosterone level you are going to use to diagnose late onset hypogonadism. But if you use very liberal cutoffs of 350 nanograms per deciliter for diagnosing late onset hypogonadism, you will find a lot of overlap between what looks like midlife crisis and what looks like late onset hypogonadism, and these two syndromes will go together. But if you use much more stringent criteria of 216 in individuals less than 70 years, which is the Endocrine Society of Australia guidelines, you would not have, you would have two different populations, one who has midlife crisis, nothing to do with late onset hypogonadism, and another set of patients much older who have what we call late onset hypogonadism. So again, depending on the cutoff, you're going to get a lot of overlap between these two clinical syndromes. Now, the final question is, if we do believe that not all of this, I'm not completely convinced that all of the male midlife crisis is going to give you a hormonal component. Some of it very well will be psychological, and we are all aware of what are the psychological issues that you're going to get. but some of it may have a hormonal component. If you're going to use a more liberal definition of late onset hypogonadism, like the European Urological Association is asking, then you have to ask yourself, is the testosterone replacement therapy going to lead to any benefits on the components of what we think is male midlife crisis? So I think I did not have any data about testosterone replacement therapy with midlife crisis. So that is the reason why the benefits that I am talking about is going to be in relation to late onset hypogonadism. I think we are very clear. Again, there was a question in Sudeep's this thing that testosterone replacement therapy in late onset hypogonadism is going to improve libido, is going to improve erection, is going to increase sexual activity, but there is going to be no improvement in ejaculatory function. So that is, again, Sudeep's choices I could not understand because he put all of these separately. I'll be very interested to hear which is the correct answer. There is definite improvement in terms of improvement in volumetric BMD. I'm sure all of you know, but that is not so much of concern with midlife crisis. There is no data on fractures. Now, male midlife crisis is primarily a psychological disorder. Are we going to get improvements in the psychological dysfunction that we see in midlife with testosterone replacement therapy? Again, here, the box is slightly lesser green. That means it is not very clear that you're going to get, but most of the testosterone trials have shown slight improvement in mood, slight improvement in depressive symptoms. But if you look at patients who are clinically depressed, these have not shown any improvement in clinical depression at all. And then obviously there are improvements in fat, free mass, muscle strength, unfortunately, to no improvement in gait speed or disability. So I'm sure there are going to be more sessions on late onset hypogonadism, but if we assume these two syndromes to go together, you are mainly focused on the psychological issues here. And I would think that there is only a very little data which shows that there may be a slight improvement in mood and depressive symptoms, but definitely no improvement if you have very significant clinical depression. The testosterone replacement therapy is not going to help you with that. And again, most of the testosterone trials have not shown any change in cognition, so that's not going to help you. So I think I'm nearing my end, and this is my last slide. So whether these two are common syndrome or this is completely different, this is something that I cannot answer. This is a contentious area. But whether middle-aged men are suffering hormonal deficiencies or they have psychological problems, they should not go untreated. So that is, I think, my take-home message. It may be hormonal deficiencies, it may be a psychological problem, but we still need to recognize them and we need to treat them. All of it may not be possible with hormonal manipulation, then we have to refer them for appropriate psychological management as well. So I think I'll stop here. And this is another thing. One of my primary sites for medical this thing is SkyHub. I'm sure many of you have used it. And the founder of SkyHub is now probably reaching middle age. And for the first time, whenever I download an article there, she starts waving at you. So with that, I'll stop and I'll stop sharing my slides and I'll be happy to give it back to the chairpersons.
Thank you, Dr. Zubin. That was a wonderful talk. You summarized this beautifully. I think the last slide that was the actual answer for whatever you are told. Whether it's psychological or hormone, we don't know, but then it should not be left untreated. I would now invite comments from Dr. Bulent, and then we'll take up questions after this.
Yeah, I think it was a very informative lecture, and some parts, I believe, as medical endocrinologists, we don't pay attention enough, but all of them we see are closely linked to hormones. And also, there are still a lot of controversial areas, especially for testosterone replacement. So I think we would need more high-quality data to make, evidence-based decisions for our patients.
Thank you. If there are any comments or questions, so let me begin with a question. Now, what about treatment of treatment with testosterone therapy, what is the role in cardiovascular disease? Will it worsen? Will it be better off? What is your comments on that? Because this is a gray zone. Nobody is sure what the cutoff should be. And then if you unnecessarily give them testosterone therapy, we may end up having more mortality, though there could be some improvement in the sexual desires, etc. But then overall, the lifespan may come down because of cardiovascular disease.
Dr. Ganapathy, I mean, if I have to answer it, I think as endocrinologists, we would only treat late onset hypogonadism for sexual symptoms. That is a primary symptom we are treating. And when we treat them for sexual symptoms, we also give them this warning that you may have a little increased risk of cardiovascular disease. If you are willing to take that increased risk, I can prescribe you testosterone. That is how I would look at it. I would not, it is definitely not going to benefit in terms of the older studies suggested that you might get cardiovascular benefit. That definitely does not seem to be the case. But there are risks. But if the sexual issues are warrant that the patient require testosterone, I don't think we should keep it from him just because of these cardiovascular issues.
Okay, thank you. Yeah, I do agree with you what you told about the socially prescribed timetable for ordering of major life events. I'll just give an example. We had a resident, so at the age of 40, she moved to the United States, applied for residency, and then she wanted to do endo fellowship. Got good marks, but then they were a little bit hesitant. Now, why at this age you are joining? So so you must get everything at the right time, right age. Only then it does matter. So I think there is a timetable for all these events. So that's a real good thing. And then the second comment is, see, now that our lifespan is increasing, maybe even 75, 80. So in the Hindu culture, we have this at around 58, 60, we have this homas we do because you are getting retired from job, your child is growing up and you'll have to get them married. You don't have a job now. So to prevent that, actually, in the sense, some rituals are actually conducted in the Hindu culture, actually. So keeping actually this in mind itself, I feel. So that's how the events, and then you're also entering into the andropause, menopause in the women, all these things telling. So it is there even from times immemorial, all these things are there. So it's something new. So that's what I want to tell. Any questions, Dr. Sudeep or Dr. Sheila, Rag, Hari Kumar?
So I think it was something very unusual, and bringing these two things together is probably a way forward. But I'm not sure whether these two things are the same.
Yes, Dr.
I
Sheila.
just have a small comment to make. I just started when you were showing about the Trump's photograph. Sorry for being late, but I thought I was in time. I thought he is past midlife, but you have put him in midlife. I'm sure you will keep him as an advisor in future.
No, I was just, I mean, the same set of issues that if a young person exhibits, it's not considered a crisis. It's considered he's ambitious. He wants he's adventurous, he's ambitious. Now, if a middle-aged person exhibits the same set of activities like doing some adventurous activities, buying a motorcycle that he's never had ever in his life, it's considered midlife crisis. So that's what I was just highlighting, that it is the social conditioning or the social acceptance that gives that term crisis there.
I think these numbers are going to slowly get blurred, sir. I mean, increasingly, these numbers, it's finally all a question of a number up there. So what Dr. Jubil was saying, that, it's the numbers are also differently defined by different people, by different cultures. So I think there is going to be a lot of sea change in the thought process. Like conventionally, we never believed that, late onset hypogonadism really existed. I mean, if you look at cultures across, you had, for example, a third wife or fourth wife at, even in the elderly population. So I think a lot of new knowledge will definitely add to this entire concept of what do we really mean by a midlife crisis? Is it really psychological? Is it social? Or is it hormone? I think very, very relevant lecture. Fantastic lecture, Zubin.
I just maybe diverting slightly. See, I mean, India and Southeast Asian phenotype, we all blame that we are a decade earlier in metabolic disorders everywhere. If you look at the current perspective, the COVID mortality also, we are a decade younger. We are seeing more of 40s and 50s guys dying than West, where 60s and 70s are dying. I mean, do you think that we are aging fast physiologically as a nation or maybe as a race? Has it got something to do with us per se? I mean, metabolic disorders, I can agree, but not infectious diseases. What is your comment, Dr. Zubin?
I think the infectious disease is also on a background of metabolic disorders. So what the metabolic milieu that a 60-year-old in the Western country has, we have it at the age of 40, 45. That's why we are likely to be dying more earlier with COVID and infections like that compared to the West. I don't think it is separated. Metabolically, we are worse off at 40, so we are likely to be worse off when an infective disease, which will look at your milieu and decide whether to spare you or take you to the ICU. So we do worse there as well. So I don't see a dichotomy there.
So maybe our midlife is early. We have already passed our midlife.
Yes. So
hopefully without a crisis.
I beg to disagree.
No, but then
it was nice presentation. Thanks.
Mortality is actually quite low, no, 1.7 or something like that. They keep telling it. Compared with the, see, now we have around 53 million people with that, and it's around 86,000. It's quite less, you can say 1.7%, something like that. So if you take that aspects, then the elderly should not have been even got it. Middle age, yeah, got it. The elderly should not have got it. Okay. Yeah. So any more comments? If not, we'll ask Dr. Sudeep to tell the answers for your quizzes.
Sudeep, please unmute yourself.
So as like Dr. Ganapati told, it appeared, the quiz appeared tough, but I wanted to keep some theory aspects and the hormone aspects in this part, and that was the only one which was definable as far as the PGs and early endocrinologists are concerned. So we'll go to the answers directly. The first question is about, this is only one question I had on the psychosocial sphere, and because I know Jubin will be dealing with that. So in this Erickson's psychosocial crisis, each age group has different crises, and I have mentioned some of them. And in this, the midlife crisis involves mainly generativity versus stagnation. That is what that sphere gets involved in that age group, nearly from age 35 to 40 to 60 onwards. It's 20 to 25 years. The main issue will be like what I think Jubin has also tried to point it out, that it's a leaving behind a legacy. That's what one main aspect in the mind goes on this age group. So the correct answer is choice A. So this is question number 2, according to Straw, Stage of Reproductive Aging Workshop. In early menopause transition is where actually it's more in terms of the cycle rather than in terms of FSH levels. So the answer C is a correct one. What we have seen in choice A and B is for late menopause transition. In early menopause transition, consistently there will be a delay of more than 1 week in the cycle. That's the first thing what it starts as when a perimenopausal period starts. And when it goes towards a late perimenopausal transition, you start having cycles more defined oligomenorrhea, like more than 2 months consistently for consecutive cycles or may occur, and FSH starts going above 40. So the choice is C. For question number C, beneficial effect, I agree with Jubin's comment, but what I want to tell is compared to the typical hypogonadism where there is an etiology, for example, the primary hypogonadisms or this one, where androgen replacement will have a benefit on both erectile function and libido. In aging males, the proof has been mainly for libido, and now new proof has started emerging for erectile dysfunction. That's why libido is the one where you have the benefit seen mainly. That's why I put the word mainly. Erectile dysfunction, the problem is like what you pointed out, trying to differentiate the androgen level and the erectile dysfunction, where we couldn't correlate, because some person having more than 300 still having erectile dysfunction, and some less than 300 still having erectile dysfunction. Not having erectile dysfunction. This is a problem. So it has been a problem when they want to quantify whether androgen is directly related to erectile dysfunction. There are some studies which have tried to address it, but as a choice, if you see, libido is the best component which gets best relieved when you are giving androgen replacement. So menopause rating scale include all the following domains except. This again is a slightly equivocal question, but still the later scales like Kuperman scale and all, they don't use a menstrual irregularity as a thing, mainly psychological, somatic, and urogenital components. So you can see here, like this is one of the recent ones and probably most extensively used scales. It's has 11 symptoms and each having 4 points, while psychological aspects of 4, somatic 4, and urogenital 3. In that the menstrual aspect doesn't come, and because that is not the part of the typical crisis for the individual. Rather than that, more other urogenital symptoms are taken into consideration. So in this choice, menstrual irregularity doesn't come. Question number 5, in andropause, true about the pathogenic mechanism. It's a like combination of hypo and hypergonadotropic hypogonadism. So it's basically at the level of the testis and the HBG axis. And all other 3 choices are wrong actually. It's the increasing SHBG levels where Jubin has also showed it. And so decreasing free testosterone level while SHBG goes up, and there is increased fat and increased aromatase activity, not reduced aromatase activity, and there is increase in testosterone receptor resistance. There is no declining resistance. As age progresses, there is increase in the resistance at the pituitary level also. So the choice is question number 5 is A. So in premature ovarian failure, again, this is something which we would have only teachers, experienced teachers telling us about what is the possibility of having a pregnancy in premature ovarian failure. There is a small but a definite chance of ovulation and a possible pregnancy in premature ovulation. That's what we are trying to highlight here. And it has been shown that if the FSH level is suppressed to less than 15, there is a possibility that ovulation can occur. So the choice here is actually more severe because it's much more abrupt compared to natural age menopause. And while replacing estrogen, the target E2 level should be more than 100. Most of the studies tell 60, but some of them tell targeting above 100 is where in a premature ovarian failure you have a more better outcome, because this population is different from the natural menopause age where we need to give a lesser dose of estrogen. But in premature ovarian failure, you have to give a proper dose of estrogen. That's why combined pill is not the obvious one. We try to mimic the same thing what happens in a natural menstrual cycle. So combined pill is not the effective one, and the symptoms are more severe. E2 levels should be more than 30. It should be more than 100 usually. So the next question, the most correct statement regarding vasomotor symptoms. Actually, it's both B and C. So estrogen level, I wanted the most correct statement in the choices. So B and C has both components. So estrogen withdrawal reduces the threshold for sweating response to core temperature change. And simultaneously, there is an increase in the norepinephrine level, which exaggerates this. And that is where you have the vasomotor symptoms. So going to question number 8. all are true about androgen levels. I think Jubin told about this. The thing is, the choice in choice B, the proportion of the distribution of testosterone is different. Actually, free testosterone only 2 to 3%, and the SHBG bound testosterone is only about 45%, not 85%, and the remaining is albumin bound, loosely bound testosterone, which is bound to albumin nearly around 50%. So the proportion of this one, what is given in the choice, is wrong. And as already pointed out, sample should be taken preferably in the morning. And if you take hormone levels as a marker of andropause, most of the literature now tell that this starts coming down by age 40. So on an average per year, there is a 1.5% fall in the total testosterone level. But more markedly, the fall is in free testosterone and bioavailable testosterone by 2 to 3% per year as aging progresses. So the studies which have used total testosterone to tell that there is not much fall, and really the andropause starts by age 50 plus or 60. Like some of them got repeated when free testosterone and bioavailable testosterone was measured. So andropause, the clock starts ticking by age 40. Question number 9. This was a tough one. Basically, just to introduce some terms and also to make sure that we try to remember there are specific treatments and even among the groups of drugs which we know. So hypoactive sexual desire disorder is a sexual disorder which is acquired, and which actually is terminology used for those who didn't have this problem and then they acquired it. And so it's a treatable condition where there should not be any psychiatric illness, there is no medication involved or no other medical illness involved, and the patient shows features to suggest hypoactivity of a sexual desire. And there are some drugs which have been approved by FDA, and one is the bremelanotide. It's an injection which has been given once in 24 hours, once a day, and it has been shown to improve the sexual desire in those persons who are having this. You have to note this, that this and the postmenopausal sexual problems, including this one, are different. So that's why the second choice here is highlighting that this female Viagra is a drug which is not used in postmenopausal women with sexual dysfunction. It's actually the drug again used in a hyperactive sexual disorder in premenopausal women. So the choice is correct for HSDD, but the group indicated here is wrong. It's not postmenopausal, it should be premenopausal. And second thing is, it is not used for sexual enhancement or not used in males. And some of you have answered as continuous testosterone therapy is not used, but there are RCTs which have shown that testosterone therapy can help in this particular group of subgroup of people who are having a hypoactive sexual desire disorder. And the fourth choice is the choice is correct. It's not for a hyperactive sexual disorder. The statement is correct here. It's again a term which is useful for dyspareunia and vaginal dryness in the menopausal women, and this has shown a significant improvement when particularly but the choice of drug will be always for dyspareunia or vaginal dryness will be a local vaginal therapy, particularly when there is vaginal dryness. But this term has particularly shown to have a good effect in treatment of dyspareunia. Now coming to the last question, which is true about Indian women. This is some publications which have tried to see how we are different from the Western data. The published literature has two age groups, but they are very close together, 46 and 47.5. That is the average age of menopause in Indian women. That's the correct choice. So it's called early menopause. Actually, it occurs before 40 years, not 38 years. And that's a mean which is defined in Indian literature and in the society. And premature ovarian failure in Indian women is not 35, it's 38 years. That is 2 standard deviation below the mean age, it's 38. So the correct choice here is average age of menopause is around 47.5 years. So there are some candidates who have attempted well, and there is one candidate who stands apart from others, and the name of the candidate is Dr. Pias. I don't know whether I'm pronouncing it correctly. PIYAS. The doctor has scored maximum marks, and the prize goes to Pias. The full name here, I'm getting the full name here. Pias Gargari. Okay, there is a tie for the second place. Two of them have scored equally. That is Mandeep Sharma and Maunam Chattopadhyaya. Congrats to the winner and the runner-ups also.
Okay, thank you, Dr. Sudeep. I think that was a wonderful quiz, and Dr. Zubin, you made the topic very simple, an uncommon topic. Actually, it generates a lot of interest because something new. Otherwise, we tend to listen to the same. I would also like to thank the international speaker. So we want you in your areas of interest, especially the polycystic ovarian, androgen excess in women, the polycystic. We would like to collaborate with you on that, and also on obesity and endocrine regulation, neuroendocrine regulation. I think we can have more of these in the future thing, because now it's all virtual platforms, and hence we are having a lot of activities. So we would like to collaborate more with you. So any comments before we close the sessions?
Yeah, I would like to thank you. I mean, it was a pleasure. And in fact, it was very good that you have mentioned. I mean, we need to pay attention to both obesity, which is highly related to male hypogonadism. And in fact, before starting any measurements and treatments, we need to pay attention to the obesity. And the other interesting thing you have mentioned is, interestingly, male hypogonadism and female androgen excess are very much alike, I mean, in terms of metabolic risks. So interestingly, they have similar metabolic features. And from a clinical practice point of view, which is relevant for both PCOS and for male hypogonadism, I don't know if it is a problem, but there was this question in the quiz, the measurement of free testosterone, direct measurements in those ranges of women and male with hypogonadism is always wrong. So we should really avoid using the free testosterone measurements. And just finally, for some food for thought, in fact, we are just looking at this single time measurement hormone levels for everything. We are trying to simplify the clinics. In fact, if you go back to the older publications for hypogonadism, what you see is even in ranges that seem to be normal, first, what's going wrong is the pulsatility and 24-hour rhythm of testosterone. So even though we are trying to deal with these disorders with what we have at the clinic, I think we have a lot more to understand the sophisticated equation. Thank you very much.
Sir, rightly, we agree with you. And that's the reason we always do what is known as a pooled sample, also sampling. We take 3 samples 30 minutes apart, pool it, and then assay so that these nadirs and the peaks can be taken care of. Thank you very much for that comment. Now, I would end this module on gender sensitivity endocrinology by thanking the Endocrine Society for giving me this opportunity to chair this session. Thank you one and all. Goodbye. Bye-bye.
Bye.